Madam needs no introduction. She is a famous obstetrician, and she is my obstetrician too. I always tell that. She is very delicate in handling the patients. So many of us are, but she sets up the standards in obstetrics. We welcome you, Madam, to deliver a talk on high-resource setting. I think we have to know both because we might be held up in any of the situation. So she has got the Best Doctor Award from Dr. MGR Medical University 2010, and her field of interest is high-risk pregnancy, endoscopic surgery and teaching. Over to you, Madam.
Thank you, Aruna, and would like to congratulate you on this wonderful conference. Panikkar sir showed lot of his innovation, but mainly in placenta previa. But when you are faced with placenta accreta spectrum, which is a spectrum where the placenta gets adherent to the underlying myometrium, it does not separate after the delivery, then we are dealing with a very different situation. And it's actually a nightmare for majority of the obstetricians who deal with that. So for the postgraduates and for all of us, the normal placenta is lightly attached, and then after delivery it separates, allowing the uterus to contract and retract and thereby preventing the bleeding. But when it enters into the myometrium, we call it as placenta accreta. Into the myometrium it's increta, and through is percreta. It is a spectrum, and it is the percreta when the whole myometrium is completely invaded by the placenta where we really have difficulties. So what really happens? The placenta abnormally gets adherent to the thin myometrium due to a previous cesarean section scar or the niche, and when it doesn't heal, the decidua doesn't heal well, and there is a fibrous scar tissue. And we know for the fetus to grow, large blood vessels develop in and near the placenta. So what happens after delivery of the baby? Because the placenta is morbidly adherent to the myometrium, it doesn't separate. And if you manually separate the placenta, then we know, those of us who have actually had placenta percreta cases, we know the large blood vessels which are in the niche and in the fibrous tissue, they cannot contract. So the patient bleeds. In Panikkar sir's video, we didn't see the patient bleed, but in actual reality, they just pour, and they leads on to maternal death. It is that dreaded complication that we worry, and in my opinion, this has become the most common indication for cesarean hysterectomy. In my practice, the 5 cesarean hysterectomies I performed, they are all for the placenta accreta spectrum. And the average blood loss, if you don't take adequate precautions, it could be massive. And I am very surprised that we can manage it. Of course, you can manage it if it is just a placenta accreta. But if it is percreta, then it goes up to the bladder, and 90% of the women will require transfusion, and it causes maternal death. And that's what I am going to discuss. The placenta accreta does not obey rules, because placenta generates massive amount of angiogenic factors, and the normal blood vessels that we see in a cesarean, it doesn't happen. Even in a placenta previa, we can manage because the placenta separates and we have various measures to control the bleeding. But in a placenta accreta or the spectrum, the vasculature is abnormal, unpredictable. And we all know that trophoblast is highly invasive. So when you try to take a suture or you use a bipolar, they just tear and they bleed, and that is the problem with the placenta accreta spectrum. And you can have varying degrees, it can spread laterally, and that is really a nightmare wherein you definitely need certain measures placed. I am going to share with you the 8 cases of placenta accreta that I managed. Our first patient was, she was a clerical staff working in Shankara Nethralaya, and she got booked in Ponneri General Hospital, case of previous cesarean, and when they did a scan at 36 weeks, that is when they decided the placenta was previa, And that time, which was about 12 years ago, I was not even sensitized about this placenta accreta spectrum. So the patient was referred with bleeding, and we did not have an antenatal diagnosis of a placenta accreta. And I cut through the placenta and delivered the baby, and that was the start of a nightmare, and my learning started then. We survived a nightmare, we survived an on-table arrest. The patient just poured, and we didn't know how to control the bleeding. We called a vascular surgeon, ligated the internal iliac, proceeded with hysterectomy, nothing would stop the bleeding. By then the patient had gone into full-blown DIC, and tons of blood and blood products were given. We were actually forced to pack the abdomen just to stabilize the patient. We packed the abdomen, we just closed the abdomen lightly, we shifted the patient to ICU, and we all stayed with the patient throughout the night. The next morning, after massive transfusion, the patient stabilized, but we couldn't shift her from our hospital to another hospital, even to do a uterine artery embolization, and we needed to get the hemostasis right. So with an oncology surgeon, we reopened the abdomen, somehow managed to achieve hemostasis. The patient survived, we all survived, and from this we learned many lessons. So what were the lessons we learned? One is you need to diagnose this placenta accreta spectrum antenatally. We cannot say it is a central placenta previa, because that's entirely different. Your placenta accreta, where it completely invades, you do not have any retroplacental space, there are lots of lacunae, bridging vessels, then we are dealing with an entirely different condition than a placenta previa. And once you diagnose, you need to on table assess the extent of invasion. Never go through the previous cesarean transverse scar, and because quite a few times the whole uterus is adherent to the anterior abdominal wall, and you are not able to go above the placenta. So do a midline laparotomy and just see where the placenta ends, wherein you can make an incision completely avoiding where the placenta ends and never cut through the placenta. And you need some form of devascularization to control the bleeding, because even if you are going to proceed with a cesarean hysterectomy, how are you going to clamp the uterine without mobilizing the bladder? And in the lower segment where the bladder is there, that is where huge vessels are there and they bleed. So these are the lessons that we learned. So what did we do? We formed a team. We said hereafter any previous cesarean where they are going to report it as a placenta previa, anterior placenta previa, we are going to get our sonologist to do a scan to exclude a placenta accreta spectrum. We are going to have 2 experienced obstetricians. Believe me, it's a nightmare. And we should alert the intensivist. I would definitely ask you not to undertake it. Maybe sometimes you may get away this low resource setting. Sometimes, you will not be able to manage. You definitely need protocol for massive transfusion. You need an intensive care bed. And sometimes organ injury like bladder injury is very common because you are operating in a pool of blood. So you alert your team. So then we decided we are going to form a team. Whenever we get a placenta accreta spectrum, refer to us. So we decided that we will admit all the patients around 34 weeks, and we are not going to wait beyond 36. We will plan the C-section even if we are planning a hysterectomy between 34 and 35. And along with scan, we performed MRA in all the cases. The MRA will also tell you a little bit more, and it will also tell you if the whole uterus is adherent to the anterior abdominal wall. And the radiologist and myself, we discuss the findings. We make sure that we have adequate blood. We keep an intensive care team ready, and we brief all the other team members like urologists and vascular surgeons. Then we decided that we will take the patient to the cath lab. Place uterine artery catheters bilaterally, but we will not inflate them, and shift the patient because we don't have facility to do a cesarean in the same place where we have the cath lab. The interventional radiologist place the uterine artery catheters bilaterally. He comes along with the patient to the theatre where we do a section. We deliver the baby. As soon as we deliver the baby, we cut the umbilical cord very close, we tie it. We don't clamp it, we tie it and just leave it and quickly close the uterine incision. And after you close the uterine incision, don't leave your knots longer to pull it because they invariably tear and bleed. So put 2 Alice so that you have this kind of a hemostasis or you have the traction device. While you are doing all this, after we deliver the baby, the interventional radiologist will embolize bilateral uterine arteries, which the reduction in vascularity, it will allow you to proceed with a cesarean hysterectomy. We have never attempted a conservative management in all the cases of morbidly adherent placenta, and you can proceed in a controlled, unhurried manner. The bladder dissection when you do, that is when you get massive blood vessels. Don't just push the bladder. When you are doing a bladder dissection, all the bridging vessels, you use a bipolar diathermy. Make sure that you have good hemostasis, and we don't really bother to do a total hysterectomy. We do a subtotal, and then after that you make sure that you leave a drain because you are not very sure sometimes about your hemostasis, and this is the plan. The subsequent 3 patients that we had, it was like a breeze. We didn't have much problem. The blood transfusion was very minimal, and they stayed only for about 24 hours in the ICU, and we didn't have any bowel or bladder injury. But then the next 2 patients, I really want to discuss these 2 patients, and because we are a tertiary center where we take on placenta accreta spectrum, this patient who was booked for a cesarean in Nagarkoil, in the last day when they did a section, the radiologist felt it was a placenta accreta and she was referred to us. But when we repeated a scan here, we were so relieved it is just a placenta previa and not an accreta, so we could manage. The second lady is very interesting. The lady had a second trimester miscarriage and she also had huge fibroids. She had massive bleed, so from the district hospital she was referred to Madurai, wherein the doctor did a myomectomy. Somehow they controlled the bleeding. And after some time, the lady was having an issue of secondary infertility, and when we did a hysterolaparoscopy, to our dismay we found that the whole posterior myometrium from where the myoma was removed didn't have any muscular layer at all. So I referred the patient to another center where through laparoscopically the defect was excised, the myometrium was closed. After that we were not sure how to reinforce the myometrium, so they placed a mesh because the patient was told that only surrogacy is the option and she didn't want to go for surrogacy. And this patient wanted to definitely have a child and she conceived with IVF. And we were all very tense because we were not sure how well the myometrial closure was and how good was the integrity of the scar. And the sonologist, it was a posterior placenta over the scar, and the sonologist told us it is a possibility of a placenta accreta, but then during the cesarean the placenta separated very easily. So we have had so far 6 cases, out of which after we survived the nightmare for the first case, all the other cases were a breeze. But the last 2 cases that I am going to discuss with you, this is a previous cesarean. We only have 1 minute more. So this was a case of placenta accreta spectrum. So we alerted the entire team. The patient was taken to the cath lab, but then the patient never came to the theatre for a very long time. Then the radiologist told us that they had some technical difficulty in placing the uterine catheter. We proceeded the same way, but then to our dismay, there was so much of pouring of the blood. Once we did the section, when we were trying to go with the cesarean hysterectomy, then we realized that the embolization was not proper and the patient was really becoming tachycardic and hypotensive. And it took a while for us to realize that the embolization did not work well. So when we did the surgery, the bladder was injured. There was great difficulty in getting hemostasis. And anyway, once we thought there was reasonable hemostasis, the patient was shifted to ICU. The next day in the ICU, through the drain, she poured about 1 liter and she dropped her blood pressure and she became tachycardic. So again we consulted the radiologist and we decided to embolize the internal iliac because we didn't want to take her without that. So the internal iliac was embolized, scan showing hemoperitoneum. So we decided to reopen the lady, evacuate all the hematoma, make sure that the hemostasis was good. Relaparotomy done, clots removed, hemostasis confirmed, patient was shifted back to ICU. But you must listen to the entire story. She was hemodynamically stable, extubated, but she complained of cold and numbness in the left leg. And when we called the radiologist, he felt instead of the internal iliac, the external iliac was, it was embolized. The patient, this had to be confirmed. The patient had to be started on a therapeutic dose of heparin. Imagine we had so much difficulty getting the hemostasis, but her limb was important. Thankfully, she didn't bleed much and then she went home on day 7. So we have also learned from Professor Paley sir how you can use an aortic clamp. Instead of embolizing the uterine artery, you can embolize the common iliac temporarily, and then we need some kind of measure to reduce the bleeding when we are proceeding with the hysterectomy. I'm just going to take 1 more minute to tell you the last patient. Thankfully, the last patient was in 2023 last year. I haven't had any cases of placenta accreta. Believe me, it's a nightmare. She is a 31-year-old doctor, gravida 2 with a previous LSCS. Her first pregnancy was IVF. It was a preterm cesarean at 34 weeks. She booked with another doctor, and the scan which were done at 20 and 28 weeks showed that it was a central placenta previa with placenta accreta spectrum. So the husband came, and husband is actually a minister in the current Tamil Nadu government. The patient is a doctor. So they came to me and they said, we would like to come over to your center. Would you take over our case? And we said, okay. But on a Sunday morning at 4:30, we received a call from the doctor who was treating that patient, saying that the patient is presented with an acute abdominal pain and her BP dropped to 80/40. After rushing in fluid, the BP came up to 160. So we thought she is bleeding internally. The placenta has completely perforated the myometrium and there should be some internal bleeding. That's why all that happened. So we alerted our sonologist and we called a vascular surgeon. On admission, she was pale, tachycardic, and she was only 29 and 5 days, and we didn't have time to do any of the intervention that we normally do. So we took her up, we did a scan quickly, confirmed there is blood in the hepatorenal pouch and free fluid in the abdomen confirming internal hemorrhage. And this is a picture, it's not very clear, taken in the morning when we were all in a hurry. You can see that the placenta has completely perforated the uterus, and at 29 weeks and 5 days, she was having internal bleeding. And so we went about, delivered the baby, and we did an internal iliac, and then the patient went home well. So just to conclude, do not take placenta accreta spectrum lightly. Antenatal diagnosis Pre-op planning, preparations, they are very, very important. Availability of a blood and blood products is a must. And we definitely need a multidisciplinary team and an ICU facility. Midline laparotomy, upper segment incision avoiding the placenta, and you need some form of devascularization of the pelvis for you to do your surgery properly. And if you have a positive experience, because in these 6 patients, any patient we would have lost, but for the support that we had. So as we all say, saving mother's life is the most important thing. So I would like to conclude thanking all of you for this opportunity, especially Aruna, and allowing me to share my experience. You enjoy the remainder of a day because it's Onam, and Onam wishes to all of you, and thank you for the opportunity.
Thank you, Dr. Nirmala, to take us through a very common problem which I'm sure each and every obstetrician is facing. For this, we really require a high index of suspicion. Nowadays, even with previous one cesarean section, we are seeing these problems. So as you had already shown in the last case, so we need to have a very high index of suspicion. Most of the times, it is diagnosed using ultrasound. We don't really require an MRI because nowadays we have good high-end machines, and it really, and most important is keep your blood products, keep your anesthetist, and always call for help. At least a faculty member, wherever you are, should be available, because no point asking for help when you have taken her up. Once you know it is placenta previa, doesn't matter. Better to have a second person for help. And I know the skills for internal iliac artery ligation has come down, but still it's very important in many of these situations when we don't have facilities for uterine artery embolization as many centers. Nowadays, I think many centers do have, but still having a skill of how to ligate a uterine artery, how to do internal artery ligation is important. And of course, sometimes these cannulas, not for placenta accreta, in case of placenta previa, this suction cannulas are helping us a lot. With that, I think Madam has to say something.
Congratulations, Nirmala. That was an excellent presentation with the good clinical illustrations. The lessons, what we should learn is, the best place to have the placenta and the uterus is in the posterior wall in the absence of any scar. Next is early diagnosis. When you have a suspicion with the ultrasound, confirm with an MRI and refer the patient to the facility where they have the all facilities. The multidisciplinary team is available with, of course, with the catheterization, catheteric embolization of the uterine artery. So this we should remember, we should not hesitate to refer the patient to the facility where it is available. Thank you very much for that excellent talk.
Thank you so much, ma'am. Thank you, ma'am.